Why not destroy the Great Saphenous vein? The technological means to destroy the Great Saphenous vein are becoming more and more numerous. Nevertheless, this destruction is disputable for scientific and ethical reasons. Saphenous vein graft can save limbs and life, avoid amputation, and coronary bypass. As young vascular specialist, I was upset by few, nevertheless too many patients not eligible for vital venous arterial bypass because of previous saphenous ablation. Two meta-analyses show that infrapopliteal venous bypass remains the best method. Two studies show that no-touch technique of saphenous vein harvesting provides significantly higher patency than the conventional technique, and that was still comparable to that of the LITA. Why destroy the saphenous vein without warning the patient? This patient had 5 coronary bypass with the right saphenous vein despite his varicose. And now we will use the left saphenous vein as a bypass for the obstruction of the popliteal vein. The informed consent about varicose vein treatments must include this very important information. Great saphenous vein in normal and varicose people can be harvested to treat a life-threatening coronary of lower limbs artery disease. Indeed, contrary to what is falsely claimed, great saphenous vein in varicose patients are eligible even if refluxing, which is confirmed using great saphenous vein stripped in varicose patients, then cold stored and sold as allografts for arterial bypasses in other patients, despite it is not as good as autologous. In France, Bioprotec sell great saphenous vein of variable caliber from 3 to 10 millimeters, previously stripped from varicose. Venous grafting is still used for below-knee bypasses in case of failure of other revascularization procedure, replacement of infected prosthesis or bypass surgery in an infected environment, and creation of vascular approach for hemodialysis. The level of performance of cold stored venous allograft is inferior to autologous vein source. In France, in 1 year, 3,000 patients needed cold stored great saphenous vein bypasses because of no more available personal great saphenous vein. Nevertheless, only destructive treatments are most of the time proposed: great saphenous vein surgical stripping or endovenous destruction by sclerosis, foam, laser, radiofrequency, glue, steam, while conservative methods exist. Lack of patient information regarding loss of chance for vital bypass due to venous ablation and conservative methods is unethical and illegal. Despite benign disease, varicose veins and venous insufficiency can give symptoms and signs that impair quality of life, and severe traffic disorders are as ulcers. So, treatments to treat signs and prevent complications are recommended. Is there any conservative treatments? Yes. Are they as good as ablative? Yes. Are they more invasive? Less than stripping, slightly more than endovenous ablations. Are they less safe? No, because light superficial surgery on local anesthesia and non-invasive doesn't mean safer. More and more sophisticated devices are proposed and sponsored, intended to facilitate the old diagnostic protocols and destructive ablative treatments. However, conservative treatments exist thanks to a better knowledge and understanding of venous hemodynamics. Conservative treatments are based on physiology, to say restoring the physiological conditions for skin drainage. They consist of transmural pressure reduction by skin compression to increase the mucocirculation and vein external pressure, and/or feet elevation, correction of incompetent effects by Shiva, and/or obstacle liberation to decrease the intravenous pressure. Destructive treatments are based on varicocentric theory. It is the stripping since more than 1 century, with the stripping by Mayo Babcock, then sclerosis stripping, and now still radiofrequency laser foam glue and stripping. The conservative theory is based on hemodynamic centric theory. More than 1 century ago, Trandambull and Brodie made the first hemodynamic treatment by treating the venous insufficiency just by ligation of the Great Saphenous vein without destruction. And then it was overlooked, this aspect, for more than 90 years. Today, since now 30 years, we propose Shiva as an hemodynamic and conservative treatment. Whatever the symptoms, venous insufficiency is always due to an excess of transmural pressure. Hemodynamic conservative therapy reduces transmural pressure. How? By increasing extravenous pressure with compression, by lowering intravenous pressure by posture, elevating the feet, and by suppression of the obstacles. Shiva treats by gravitational hydrostatic pressure fractioning, shunt disconnections, and respects of drainage. Skin compression is in any case recommended because it exerts an external pressure which opposes this excess of endovenous pressure whatever its cause. Elastic band and stocking compression. Elastic compression is not passive but active due to its potential shortening force, and stores instead of resisting part of the pressure volume variations of the limb. An elastic compression does not have the same therapeutic virtue. For a lesser subbandage pressure in lying position, an elastic bandage reduces more transfemoral pressure than elastic bandage during standing and walking. It reduces the risk of ischemia in lying position, which is essential in case of associated arteriopathy. Nevertheless, due to its better conformability, elastic compression remains preferable for all the case of transfemoral pressure is not too high, which is fortunately most of the frequent cases. Unfortunately, the pressure of the anelastic compression decreases during the day when the edema volume of the leg decreases. The prior reduction of edema by elevation of the leg combined with the light elastic bandage limits this disadvantage. Doppler flow monitoring prevents ischemia. To reduce endovenous pressure due to gravity by posture, avoid long periods of standing still or sitting. Lie down and better 11 feet. Combined compression plus feet elevation reduces even more the transfemoral pressure by increasing the external pressure and lowering the intravenous pressure. Whilst most of the time efficient to treat ulcers, pain, aesthetic concerns, and to reduce or suppress uncomfortable elastic compression, destructive ablations of the great saphenous vein destroy a potential vital venous graft to treat life-threatening arterial diseases and prevent not recurrence. Saphenous vein for peripheral and coronary bypass avoid amputation and save lives. As young vascular, I was upset by few, nevertheless too many, patients not eligible for a vital venous arterial bypass because of previous saphenous ablation. This is why I decided to find a treatment that combines the cure of the varicose veins and the conservation of the saphenous vein against more than 120 years old destructive dogma. I analyzed the academic pathophysiology and found great lack of hemodynamic concepts. Thanks to Doppler ultrasounds, I could understand better the venous hemodynamics, and I proposed new concept of the venous pathophysiology that led me to conservative surgery of the venous disease named Shiva. I published my findings regarding the Doppler semiology of the vascular disease in the first world book of Doppler vascular semiology. Then I patented a device that made possible for the first time in the world the echo-imaging of the superficial veins and arteries. This device gave a sufficiently good imaging to make me write the first world book of ultrasound vascular imaging. This background made me easier the checking and revisiting the Venus hemodynamics that led to Shiva. Books about Shiva and books about Venus insufficiency. These studies led me to propose new concepts based on the central role of transmural pressure in the venous functions of drainage, cardiac filling, and hemodynamic processes that regulate it. Shiva is a method which results from these new concepts. It is a French acronym from conservative and hemodynamic treatment under local anesthesia of the venous insufficiency in outpatients. The new concepts of venous insufficiency and their Shiva consequence are: valve incompetence is responsible for closed circuits which overload the veins and are named closed shunts to be disconnected. Excess of gravitational pressure to be fractioned. No venous ablation to respect the drainage, especially the Great Saphenous vein, which is, despite incompetent, eligible for eventual arterial bypass. Shiva's strategy is tailored according to the hemodynamic pattern of the various shunts assessed by echo Doppler and reported on a map. Here is the mapping of two cases, for example, here with the flow direction and so on, and here the marking 1, 2 here on the right, 1, 2 on the left, here 1, 2, 3 on the right, 1, 2 on the left. It's the site of marking and for disconnecting under local anesthesia of the various shunts. So the both Shiva purposes, saphenous conservation and varicose treatment, are achieved. The venous drainage is restored thanks to the both conservation and draining function of the varicose veins, provided good results in terms of function and aesthetics. Ablation and Shiva play on the same venous system board, but ablation obeys the simplistic checkers rules and Shiva the complex chess rules. As the venous function is complex, ablation doesn't fit the treatment of the venous dysfunction. All the studies, trials, and RCTs validated Shiva as better than ablative procedures, surgical or endovenous. 107 articles and 9 books published on Shiva treatment. RCTs and Cochrane provided the evidence of better or at least even the results of Shiva versus all types of ablative procedures. The last review rates Shiva achievement better than ablative methods. Here is Shiva and here the other methods like stripping, ablation and stripping, sclerotherapy, ligation and so on. And here we have Shiva rated as better at the others. The learning curve is steep, but the result is worth it. The learning curve is steep, but the result is worth it. Prendi così e dopo gli faremo la prova
Di perso.
vedere come si sgoccia.
No.
Così sarebbe più bello. Sì, sì. Vedere come si sgoccia.
No.
Così sarebbe più bello. Sì, sì, sì. In confronto a quello che va prima, aspettiamo che si va.